everyone. Welcome to our today's session entitled Breast Reconstruction. When someone is diagnosed with breast cancer, survival is the first priority, but quality of life and feeling comfortable with your body are also important considerations. And breast reconstruction surgery is often a key part of the recovery process. We are glad to welcome Dr. Sebastian Winocour, Associate Professor of Surgery in the Division of Plastic Surgery at Baylor College of Medicine. We are going to have an overview about this very important topic that has a big impact on the psychological and emotional well-being of women who underwent breast removal surgery. Welcome, doctor. We are glad to have you with us today.
Thank you, and I'm glad to be here.
So, Dr. Sebastian, we know that reconstruction is a very personal decision. How do you approach patients after breast removal surgery?
So you're absolutely right. It is a very personal decision. We talk about shared decision-making in breast reconstruction surgery, and that's really my job as a plastic surgeon is really to empower patients to have the knowledge to make decisions that are right for them. So fortunately, there are many options in breast reconstruction, and not every option may be available to a patient, and not every option may be desirable for a patient to choose. And so my job is to really present the pros and cons of each of those and allow patients to go home to their families and their friends and their loved ones and come up with a decision plan that's right for them at that stage in their life. And then try to fulfill that. We try to meet their expectations, and really our goal in all of this is really to restore their breast and restore their personal and emotional well-being.
So, doctor, we know that there are maybe two types of breast removal surgeries. Can you tell us how do we go over these two processes?
So what you're referring to is many patients have the option to undergo a lumpectomy with radiation versus a mastectomy. And not every patient may be a candidate for both. Usually that's a decision made with the medical oncologist and the breast surgeon. And although the plastic surgeon does play a really integral role in explaining kind of the differences between those two options. But one of them, a lumpectomy with radiation, is really what we refer to as breast preservation surgery. And so the goal is to preserve what's there in the breast and try to make that look as good as possible, versus the alternative, which is a complete mastectomy. We are replacing the breast. And so there's pros and cons for each. They're both good options for each, but the situation may be different. And I'll give you an example. For example, a patient who has breast cancer, who has a genetic mutation that increases their risk of future breast cancer to a point where it's extremely high, they will not be a candidate for a lumpectomy, and so they will not be able to preserve their breast. They need to remove that breast tissue for future risk of their breast cancer as well. So that's so you
take this decision along with the oncologist, I think.
Correct. And so that decision is made between the geneticist, the medical oncologist, and the breast surgeon. In that situation, they really don't have an option for a lumpectomy. But most patients do, and we talk about those options, the pros and the cons for each.
And doctor, what are the types of breast reconstruction that are available now?
So in the case of a lumpectomy, for example, there are options where we use what's left of the breast tissue to move tissue around to try to minimize any deformity and really restore the breast. There's other options for patients who were candidates for breast reductions or breast lifts. We can do a lift or a breast reduction at the same time as the lumpectomy, take out the cancer, and actually make the breast look as if you never even had a cancer. And this was a cosmetic or reconstructive breast reduction. Versus if you had a mastectomy, there's really two categories of reconstructions that we talk about. We either talk about using implants or we use your own tissue. And there's pros and cons for each. And some patients are not candidates to use their own tissue, but one of the advantages of using your own tissue is that it really gives a natural feeling and appearance to the breast, and it allows us to remove tissue in areas that it's typically unwanted, like the abdomen or the thighs. And so that really, for many patients who were thinking about having a tummy tuck or an abdominoplasty already, we're using that tissue, we're giving them that result, and then we're using the tissue to restore the breast where they need it the most.
Mm-hmm. And doctor, in case of lumpectomy, is there any chance that there is a symmetry between the two breasts? How do you do that?
Really good question. We operate on the other breast as well. Our goal is symmetry. So, for example, if we're doing if the breast surgeon's doing the lumpectomy for cancer, and I'm doing a breast lift on that side where the cancer is, I often do a breast reduction on the other side to match the cancer side, the breast on the cancer side. And so that's a perfect example where we do symmetry procedures. There's other options where we can, for example, when we do mastectomies, we will do surgery on the other breast as well in order to match that. For example, if we make a breast that's larger than prior to having the mastectomy, we may make the breast larger on the other side.
And doctor, there's a concern for, I think this is the most concerned matter for women, is the reservation of the nipple. So sometimes nipples are also removed during the surgery. So what are the options for women for nipple reconstruction?
So obviously, nipple preservation is really important. So if we're able to preserve the nipple in a nipple-sparing mastectomy or a lumpectomy, where we can preserve the nipple, we want to. But in the event that we have to remove it, there are excellent options, and there are even better options today than there were 10 years ago with nipple reconstruction. We can build a nipple from scratch, where you can have a projecting nipple using tissue locally on the breast. Three-dimensional areolar tattooing is the latest technology that allows us to give you the visual appearance of an areola that gives you the illusion that it's three-dimensional, even though it's actually flat. And we can even use that technology to build the nipple as well. So we can do complete nipple areolar tattooing with creating the illusion. And many women can even go online and they can see photos of these tattoos that look incredibly realistic and really give the illusion that it is truly their native nipple areola.
And sometimes for the reconstruction of the nipple, you use like other parts of, you take like skin from other parts of the body, and you.
We do. Less so than we did before. Often we take skin from areas where the color is darker to match the native areola. We can take skin from the areas in the groin, but we do that less so today. The technology for three-dimensional areolar tattooing is so good now that we rarely have to take skin from elsewhere.
Okay. And doctor, can you tell us about the DIEP flap breast reconstruction, and who is candidate for this kind of operation?
So it's a good question. So this is using your own tissue from your abdomen to reconstruct the breast. This is what we call a microvascular technique. So we hook up really small arteries and veins to really small arteries and veins in the chest. The patients will get a tummy tuck out of it. So this is a really nice way to get rid of unwanted skin and fat and use it in an area that we obviously need to restore a breast. Patients that are candidates, for many surgeons, their cutoff is an age of 60 or 65 years old. So patients younger than that are candidates. Also patients that have not had extensive abdominal surgery and who are able to undergo not a riskier operation, but a longer operation, because it's technically requires a lot of technical precision and expertise. And so when you're working with under the microscope, things take a little bit longer.
And you do it at the same time with the breast reconstruction. And also at the same time with the breast removal?
So
is it possible to do that?
Yeah, so immediate reconstruction is always the goal if we can do that. We see better aesthetic results if we can restore the breast immediately. So if we could do a deep flap at the time of the mastectomy under the same anesthetic, this would be the ideal circumstance. Not everyone can have that though. There's certain situations where patients may need to undergo radiation after therapy, and we know that up front. In those patients, we want them to undergo the radiation first because the radiation can injure the skin, and we may be able to remove that skin and replace it with skin that's not radiated. So in those situations, when patients are undergoing radiation, we typically want to kind of delay the final reconstruction. We may put in a tissue expander or a device that allows them to keep a breast in clothing, but not have the final result so that they can go about their day-to-day life and not feel that they don't have a breast. But ultimately, we want to remove that radiated skin and replace it with non-radiated skin. And in that situation, we wouldn't do the deep flap right away.
So usually doctors, they recommend to stay take a break after the surgery and after having the plastic surgery later on. They say you have to put like some skin. I don't know what kind of to extend the skin. I mean, before the surgery.
Right. So
this only used with the mastectomy, yes?
Correct. Yeah. So we put in what we call a device called a tissue expander, and that tissue expander allows the skin to recover for a week or two before we're able to expand the patients in the office.
Okay.
We put a needle through the skin into the port, and that expands the skin and it expands the tissue expander, and it takes advantage of the fact that there was extra breast skin to begin with. Okay. And we are able to stretch the breast skin over time to the volume that the patient desires, so the size of the breast they want. And then we wait a period of time, usually in the neighborhood of several months, waiting for the patients to undergo the additional therapy that they need. Okay. And then once they've done that, we can electively schedule the final stage of their reconstruction once they have completed therapy.
And for the flap surgery, if the patient doesn't have excess skin, for example, or excess weight, is it possible to do it?
It is. We look at different donor sites. So, for example, we may not be able to do the DIEP flap, but we may be able to do flaps from the upper thigh. Many women have a little bit of extra medial upper thigh fullness, and so we could do flaps called the profunda artery perforator flap or the PAT flap. We can also take skin and fat from the upper buttocks, although this is less preferred now that the medial thigh flaps are becoming the second choice after the deep flap.
After the deep, okay. And doctor, for example, if a patient had the choice between the two surgeries and the patient is a candidate for the two surgeries or using implants or having their own natural tissues used, so which one do you recommend?
It's a really good question. I mean, it's a personal choice. I practice in the United States, and in the United States, 70% of all women choose implant-based reconstruction, and 30% choose using their own tissue. And that's from a variety of reasons. Some patients aren't good candidates for using your own tissue. Some patients prefer shorter surgeries from using implants. The advantages and disadvantages depend on the patient you're talking to, really, in terms of the pros and the cons for them. But for example, the DIEP flap, when you use your own tissue, the longevity of the reconstruction is very good. They often last a lifetime. They're more natural. So we talk about kind of upfront pain for long-term gain. So we're talking about surgeries that have a longer recovery, but have more longevity over time.
And at the same time, you can, for example, if there's asymmetry between the two breasts, you can use fat to put in the other one also to be symmetric, to have the symmetry.
Correct. There's many adjunct procedures that we can use in breast reconstruction. One of which is fat grafting. We perform liposuction anywhere on the body, and this is usually very desirable for patients where they can choose where we can take the fat from, and then we inject the fat into areas of the breast that need it. So we can correct any asymmetries, any deformities. We can make breasts larger. And fat grafting has been proven to be a safe and effective technique, and it can be done multiple times. So many patients will come back and desire another round of fat grafting, but it's a really important adjunct to help these patients achieve their goal.
Okay. And doctor, can you tell us about the last and best implants available in the market? We know that before a patient, maybe the implant won't last for long, for example, maybe like 5-10 years, and they have to remove it later on and put another one. So what are the latest? Is there anything that can last longer than 10 years, for example?
So the technology for breast implants has never been better. We're on the 5th generation of cohesive gel silicone implants. So these are from the major manufacturers. These are gummy bear implants. So they no longer have liquid silicone. They're all cohesive gel, just like a gummy bear. They don't leak out. They can fracture still, but the silicone won't leak out as a liquid. And as a result, the longevity of these implants has increased. In the 4th generation implants and prior, we used to say that we used to recommend for patients to have their implants changed out every 10 years. Now, with the 5th generation, we no longer have that recommendation. So patients are able to go their entire lives with these implants. We typically still see patients coming back every 10 to 15 years, desiring some sort of revisional surgery. But nevertheless, the implants are the technology now is so good that we don't recommend an automatic replacement at 10 years.
Can we talk about the risks and of complications after surgery? If you want, we can start with implants, for example, and then later for the DIEP flap.
So, and with any type of surgery, there's always some risk. I think the risks are low, and I think in general, the vast majority of patients don't have any complications. Nevertheless, when we deal with implant-based surgery, just like any foreign body that we implant into the body, there's always a risk of infection, and there's always a risk of the body not rejecting the implant, but creating scar tissue around the implant. So what we call capsular contracture. And while it's normal to form a little bit of scar tissue around the implant, some patients can develop a lot of scar tissue, which is pathological and not healthy. And sometimes we have to go back and remove that tissue. So those are the specific risks that are particular to breast implants. Whenever we're transferring tissue, for example, with the DIEP flap, there's always a risk that the tissue can die. That risk is really low. For example, the flap loss rate for a DIEP flap is about 1%. So 99% of patients, 99% of flaps that we transfer from the abdomen to the belly do extremely well. And so, so as you can see, just based on those numbers, the risks are low, but there are specific inherent risks to the operations that we always discuss with the patients. And we try to mitigate those risks by doing a variety of things to try to prevent it.
Doctor, can you tell us, after your extended experience with the women undertaking these kind of surgeries, what is the psychological impact of the surgery on women?
It's a really good question. I mean, I think that there's different stages of coming to terms with a breast cancer diagnosis. It's a really challenging situation, and it really it's an emotional experience for patients as they go through the reconstructive process. I often see patients at the very end of their breast cancer treatment, and while a lot of the shock of the diagnosis is already been experienced by the patients. Many of times they have not come to grips with everything, and only during the reconstructive process, once they're seeing the impact on themselves, they've actually reflected back on what they've gone through with the treatment, do a lot of their emotions come through. And so it's a very humbling process to be in my position and really look after patients, because you have to have a tremendous amount of sympathy for what they're going through, and really take the time to make sure that they understand their options, and that they really they make decisions that are right for them. Because in some situations, I have to spend a significant amount of time with patients, see patients back multiple times, just to make sure that I feel comfortable that they have made a good decision for themselves. And so it's a very a privileged position that I am to be able to look after these patients, and it's a challenging scenario, and it's far too common. Breast cancer affects 1 in 8 women, 12% of the population. Everybody knows somebody who either has been affected by breast cancer.
Yeah, a parent or a friend, or of course, yes, this is becoming so common that we hear about it everywhere. So, doctor, what is your message for women out there? For some women refuse to have like reconstructive surgery after a mastectomy, for example. What is your message? Is this the right choice, or it's a personal choice, or do you advise them to go through it because it will give them more, confidence and emotionally, socially and emotionally? I don't know.
It's a really good question, and there's no right answer. Nobody should be forced to undergo any procedure that they do not want to go to. And many patients that don't go through reconstruction are extremely happy and satisfied with the decision. I think it's important that patients are educated and are knowledgeable about the options that are available, so that they can make a decision. That decision may not be to have breast reconstruction. That's a perfectly acceptable option. So, but I think it's important that that patients meet with plastic surgeons so they know what's available. One of the greatest challenges that we face here in the United States is that many patients don't have access to a plastic surgeon, and so they don't know what options are available to them. And so, so I think it's important that we create a system where people have access. They can develop access points so that when they're diagnosed with breast cancer, they know what options are available to them, so that they can make those decisions for themselves.
Thank you, doctor. Would you like to add anything else?
No, well, thank you very much for having me. It's a pleasure talking about this, and I know this really is a very it touches home for a lot of people, given the prevalence of this disease.
Thank you very much, doctor, for your all the information you gave us, and hopefully the technologies will keep going on and on, because we need it. Everyone will need it in the future at some point.
Thank you.
Thank you very much.